Folks trickling in, thank you for joining us. I'm sure you needed a break from watching the news today anyway, so great. We're glad you're here. I'm Dr. Chris Rogers, founder of San Diego Orthobiologics Medical Group. I'm joined by my colleague, Dr. Annette Ombach. We are both board certified physical medicine and rehabilitation physicians who specialize in non-surgical orthopedic care, as well as regenerative medicine, which is a new field that is based on the premise that the body can heal itself. And scientists and doctors are figuring out how that actually works. And so Dr. Ombach and I, we've both been doing this for more than several decades. And in the early days, we were injecting cortisone into people, trying to decrease inflammation. And that was fine for some people, wouldn't last very long for others. But now we're in a new era where we can actually use your own cells to heal certain types of injuries. And our job is to diagnose you appropriate, come up with the appropriate diagnosis, and then determine whether or not you're a candidate for some of these newer treatments or whether the standard of care is going to be appropriate for your condition. So today our topic is about rotator cuff tendon injuries, and they come in different grades, mild, moderate, and severe. And I'll let Dr. Ombach explain a little bit about some of the basic things we see with shoulder tendon injuries.
Good afternoon, everybody. For those of you who haven't joined us before, this is our Ask the Doc series. And this is a 30-minute question and answer session wherein Dr. Rogers and I are making ourselves available to answer questions from the viewing public regarding orthopedic conditions or any topics about regenerative medicine like platelet-rich plasma and cell-based therapies. So every session we do have a different topic, and the topic for this session, as Dr. Rogers mentioned, is rotator cuff tendon and rotator cuff tears. So I just wanted to remind everybody, you are welcome to write your questions in the Q&A box in the bottom of your screen if you are joining us through Zoom. And if you are joining us through Facebook, you can write your questions in the comment section, and then we can answer them as they come. So we want to define what are these rotator cuff muscles before we go to the injuries that is being sustained. So rotator cuff muscles comprise of 4 muscles that stabilizes your shoulder joint in place. So there's the supraspinatus, which is the muscle that elevates your arm, or what we call abduction. There's the infraspinatus and teres minor, which are the muscles that move your arm out or externally rotate your arm. And then there's the subscapularis muscle, which moves your arm in, turns it in. So we call that internal rotation. So these muscles are connected to the bones in your shoulder through a tough fibrous tissue called the tendons. And that's what we're going to talk about today. Rotator cuff tendon injuries and rotator cuff tears is very common, especially in more than 50-year-old population. We see this in almost half of the population. 30 to 50% of the population in this age group gets rotator cuff problems. So what is rotator cuff tendinopathy? What is the tendinopathy? Basically what that is your tendon is composed of fibers. And due to either age-related degeneration or trauma or wear and tear, these tendons start to degrade or degenerate. We lose also some of the cells in the tendons that keeps them healthy. And as a result, you start having these tendons that for grade 1 starts as a wavy form of fibers instead of straight and taut fibers. And as the grade progresses, these fibers degrade and breaks into smaller fragments and become, a partial tear or a complete tear. So as the degeneration progresses, the tears become more apparent. There's less tendon cells. There's more of the tissue that like scar tissue and other tissue that doesn't really make the tendon quality better. So you end up with a tendon that is weaker. Today we're going to talk about these problems. Rotator cuff tear is also caused by either trauma or age-related degeneration. So one of the most common things that we get from complaints from patients with rotator cuff problems are not only pain in the shoulder, but decreased range of motion. So before I go ahead and talk about the other tendon conditions, Dr. Rogers, feel free to add anything more about rotator cuff tendinopathy and tear.
Yeah, as Dr. Ombach said, these are extremely common, and we see dozens of them every month in our office. I myself have actually sustained a rotator cuff tear, and I can attest to the pain that it causes. But the common problems that patients have, like Dr. Ombach said, they may have pain raising their arm, they may have pain reaching behind their back. A lot of patients have pain when they sleep on the affected side because of the stress on the tendon. Things such as throwing a ball for if you're playing ball with a dog or child or somebody, that could produce pain. The ball and socket in your shoulder is not a very stable joint. You have the ball and the socket's kind of small. So there isn't a lot of bony contact. And as a result, there isn't a lot of stability, meaning the bones can move around pretty easily. And it's the ligaments and the tendons and the muscles that produce the stability of that joint. So if your tendon becomes torn or becomes weakened, then the joint can become unstable, and that also produces pain. So, for years, the standard of care, if it was a small tear, maybe some physical therapy would be helpful, anything to improve blood flow. Part of the reason the tendon doesn't heal very well is because it already doesn't have a very strong blood flow to it. And so those cells are not getting nourished like they should. But so any exercise or any activity that would increase blood flow to the tendon can produce healing. And then for the large tears, full thickness tear where the tear is actually pulled away from the bone, a lot of those would require surgery, and it doesn't heal the tendon, but it just reattaches the tendon to the bone. The problem is the re-tear rate is very high. More than 80% of patients after 10 years will find that tendon starts to tear again because, again, it doesn't heal. It's just sewn to the bone. So we see a lot of patients who maybe had surgery in the past who now have a re-tear and don't really relish the idea of going back and having surgery again. So we can help some of those folks as well. And the way we help them is with some of the orthobiologics that you've heard about. So we're going to talk about PRP, which is platelet-rich plasma. And then we'll also talk about cells from bone marrow or cells from fat tissue, which have been shown to be helpful for healing tendons. So maybe Dr. Ombach, you can tell me, what is PRP? What do we do with PRP?
Right. So Dr. Rogers mentioned there is the standard treatment for rotator cuff tendons, and then there's surgical treatments. And then what we do is something in between that's not surgical, but it's better than your standard treatments because it's designed for long term. So these regenerative treatments are either PRP or cell-based therapy. PRP stands for platelet-rich plasma, and these are a concentrated solution of platelets and plasma. And the reason why we're interested in these platelets is they contain thousands of growth factors that are involved in healing and repair. They are also involved in tissue regeneration, they decrease inflammation, and they attract all the cells that are involved for healing into that region. The other group of cells that we use in the clinic are the cell-based therapies. And these are a different population of cells that are derived either from your adipose tissue or fat or from your bone marrow. This concentrated tissue contains adult stem cells, which has the capacity to regenerate injured tissues and has the capacity to not only replicate themselves, but also to turn into or differentiate into the tissue that's needed by the body. So these are all done in the clinic. Without most of the time, patients don't need what do you call this anesthesia, sedation under IV or the surgery center setting. We only use local anesthesia for this. So we're talking about other conditions in the shoulder that can cause pain, and there's a question here. regarding how do you diagnose a rotator cuff injury versus some other types of shoulder pain?
Yeah, that's the most important question. Every patient who comes to us has two questions. Why do I hurt and what can you do about it? So the first question is important to answer first. So why do I hurt? Well, we told you that patients who have trouble raising their arm or reaching behind their back or sleeping on their side, a lot of times will have a tendon tear. Sometimes just by examining the patient, we can determine that this is probably a tendon issue as opposed to, say, a joint issue, an arthritis issue, some other cause of shoulder pain. In the office, we use ultrasound, diagnostic ultrasound. So you're used to seeing pictures of ultrasounds of babies. When mom's pregnant, you can ultrasound and see baby inside. We use the ultrasound to see your tendon in your shoulder. You might ask, well, which is better, MRI or ultrasound? Well, there are a number of studies that show that for rotator cuff tendon tears, ultrasound actually is extremely accurate and sensitive for the treatment of tendon injuries. And we can see them. And then we can, they come in different flavors, right? So as you might imagine, there are small, medium, and large tears. There are some tears that are very simple, just a little slit in the tendon. There are some tears that are very complicated. There may be multiple tears. It may be associated with bursitis, which is inflammation of the bursa sac, the little sac that protects the tendon. There may be arthritis in the joint. We can see these things with ultrasound. If we can't see everything we want to see with ultrasound, then we'll go ahead and order X-ray or MRI to look at some of the other parts that can't be demonstrated well with ultrasound. And once you've identified the tissue that's injured and the degree to which it's injured, then you can start making intelligent decisions about how we should treat this kind of problem. So Dr. Ambach, if I had a small tear, maybe not a full thickness tear, but just a partial thickness tear in my supraspinatus tendon, probably one of the most common things we see, how would you go about treating that person?
Right. The question becomes, when do we refer a patient for surgery, or when do we proceed with cell-based therapies? We have a lot of data regarding the use of these cell therapies for tendon injuries, and pretty good data that helps heal partial rotator cuff tears, partial tendon tears in the gluteus or in your buttock area, or in your lateral epicondyle, which is in the elbow. So we have good data in these cell therapies helping partial rotator cuff tear. So that's probably the first thing that I would recommend, is to start with a platelet-rich plasma injection into the tendon. And with our experience, typically patients get the result that they want with just one injection, and rarely do we have to repeat it. If the patient is a little older and their tear is, I would say, more than 50% or a little bit more involved, then I would probably lean more towards using cell-based therapies like a fat tissue-derived therapy for the tear.
Yeah, I would agree with that. And what we're talking about when we say cell-based therapies, you may have heard the term stem cell therapy, but we should be clear, there really are no stem cell therapies out there that are currently FDA approved for orthopedic applications. And what I mean by that is a pure stem cell therapy. So, 10 million little cells in a bottle. That does not exist. I understand there's people out there who pretend to do that, but that truly does not exist. The science is moving in that direction, but these treatments are not yet FDA approved because they're still undergoing investigation. However, we know that our bodies have stem cells in them. Everybody who's breathing today has live stem cells inside of them. Those are the cells that help you when you cut yourself or bruise yourself, or just generally keep you healthy when you need to regenerate tissue. We know that these cells are abundant in the bone marrow, and we know that these cells are abundant in the fat. So if we have a young patient, for example, we know that there's going to be more stem cells in their bone marrow than in an older patient. And we might take some of that bone marrow and inject it into the tendon using the stem cells. And one of the oldest studies, very well cited research study now, conducted by Dr. Hernigau, who's an orthopedic surgeon in Paris, France, has a really nice study where he injected stem cells from bone marrow. Actually, it was bone marrow itself, not just stem cells, other cells in the bone marrow, into rotator cuff tendons in conjunction with a surgical procedure that he was performing, showing that whereas all the other surgeons, their rotator cuff tear surgeries would fall apart in 10 years, or a majority, 88% of them would fall apart within 10 years. About 40% of his patients' tendons would fall apart in 10 years. So augmenting the surgery with stem cells from bone marrow is very nice. And we estimate that he was injecting around 50,000 stem cells. So not really a lot when you think that you have 37 trillion cells in your body. Just 50,000 stem cells from the bone marrow was enough to give that extra benefit for those patients. Now, if we have an older patient, we know that their stem cell count is going to be diminished in their bone marrow, but it doesn't diminish to quite as great a degree in the fat. So we found that if we do a mini liposuction procedure and rinse and wash the fat, we can then create essentially a fat graft, which is injected into the defect of the tendon. We've had very good results showing regeneration of tendon using that technique. And there are many different techniques that are being investigated, but basically they're the same. They're using cells that are found in the fat to stimulate the tendon cells to make more of those collagen fibers and make a robust, healthy tendon again. And so Dr. Ambach and I have lots of fun pictures that someday we'll put in a book, the before ultrasound images and the after ultrasound images showing how the tendon has regenerated.
So what are the outcomes for doing surgery for rotator cuff? And this is a question that we get asked a lot. And there has been variable success of rotator cuff repair. There are studies that shows that it does improve range of motion and it does improve pain. However, there are also a lot of studies that have shown that the failure rate for these surgeries are very high, and in some cases even up to more than 90%. The problem is when the tendon connects to that bone, what the surgery is not able to do is to create this cellular healing in that tendon bone interface, wherein the tissue itself is not improved. It's basically a weaker tissue that has a scar formation in it. And that's why there's still an increased rate of re-rupture in these patients. There has also been a lot of studies showing that surgical repair for partial rotator cuff tears and near full thickness are not more superior than conservative measures. And a lot of studies have shown a rotator cuff versus a repair versus physical therapy, wherein they were showing the same outcomes. So there are conditions that are surgically indicated, like what Dr. Rogers mentioned, wherein the tear is retracted, or big full thickness tears that a patient has exhausted all conservative measures with significant daily limitations. But for most of these cases, they do respond well to PRP or cell-based therapies. One of the comments that has been said here in Facebook is there's a patient that had undergone rotator cuff surgery, and at the same time they injected the patient's own cells, and she did really well, alluding to that study that Dr. Rogers just mentioned, that the combination of both seems to be helpful.
Yeah, these cells that are found in the bone marrow or in the fat or even in the blood when we do PRP with the platelet-rich plasma, those cells are not just stimulating healing and stimulating regeneration, but they're also anti-inflammatory and they have pain-relieving effects. For example, the stem cells that we find in the bone marrow or in the fat, they've been shown to release molecules that bind to opioid receptors, much like a narcotic would. So that in some ways they're functioning, these little cells are functioning like little drugstores that release drugs that decrease pain. So we find that the patients who get cells, what I would call cell augmented surgery, they recover a little bit easier. They have less pain afterwards, less swelling, and that tendon probably recovers more quickly. as Dr. Ambach was talking there about surgery, I was thinking, whether we're talking about doing surgery for a patient or talking about injecting cells, it really is we have to avoid the tendency to make broad sweeping statements, because really it has to be customized to the individual. So for example, if I'm a 30-year-old athlete and I fall and I tear my tendon in my shoulder, but my shoulder is otherwise healthy and I'm otherwise healthy, that's a different scenario for the surgeon than the patient who has been slowly degenerating that tendon, just like the tires on your car slowly wearing down,
Right.
in conjunction with maybe atrophy of the muscles, right? So now the muscles are not as strong as they were. Maybe in association with some arthritis in the joint, some inflammation in the joint. So your expectations are going to be different for different patients. And that's why it's so important when you get a surgical consult that you maybe get more than one consult, just so you can kind of hear some different perspectives about, how your unique situation might respond to a surgical treatment.
That's correct. Next question. Does insurance cover PRP? If not, what are the costs? I've read that only about 50 to 75% of PRP is successful.
Yeah, great question. So uh, I'm a doctor who spends a lot of time reading the published literature as well as contributing to it. One of the first questions we get asked by patients is, how successful is your treatment? And knowing a little bit about this field, I respond and say, well, what is your definition of success? And so different research studies use different metrics. So you could say, if I have 100 patients, how many of them will get better? That's one way of measuring success. We say, 85, 90 out of 100 patients get better. That's one way. Or you could say, of those patients that get better, what percentage improvement do they see? Well, I'd say in our patients with, say, a partial rotator cuff tendon tear, 85 or 90% of them will get better. And some of them will have complete relief. Some of them will only have 50% relief, but the average is probably around 80, again, 80, 85% improvement. And then the next question you could say, well, how long does that improvement last? Does it last forever? Or does it only last for a year or 6? If we inject steroid in there, it's only going to last maybe 6 weeks, right? So, depending on the tear, some tendons, when they heal, they're done. They're good. They're normal. They're virtually a normal tendon. They never bother that patient again. I have patients that I treated 12 years ago that had big tendon tears. They healed and they never became a problem again. I have other patients, they re-injure themselves, or, let's face it, we're all getting older every day. So things happen. But on average, we see, for a given tendon, a small tear versus a large tear, we can share with you on an individual basis what you're likely to expect from a given treatment.
There was another patient that commented that FDA should rush. If the FDA can rush the COVID-19 vaccine, they should help people by approving stem cell therapy.
Well, there's a lot more money and political will behind that effort than there is behind PRP. But you're absolutely right. Patients, they'll say, "Gosh, why doesn't my insurance pay for PRP?" I'm thinking now about our patients with knee arthritis, right? So you have damage to your cartilage, you have swelling in the knee, you have knee pain. There is more published scientific data on PRP for knee arthritis than there is for almost anything in orthopedics. I won't get into the details, but what we call level 1 evidence, some of you may know what a randomized controlled trial is. There are meta-analyses where you take a dozen randomized clinical trials and do the analysis, and they show there's no doubt PRP works. So it's not a matter of not having enough scientific validity. It's not that it's an experimental treatment. It's more of a political will issue. It's more of a dollars and cents issue, I think. I do believe it will change. It's not happening fast enough, but it will change.
Yeah, so far to sum it all up, rotator cuff tears and rotator cuff tendinopathy can be treated well with conservative measures. You've got several options. There's physical therapy, there's anti-inflammatories. In some select patients, steroid injection may be helpful. And what we're talking about, cell-based therapy and platelet-rich plasma, are probably better long-term solutions for these patients who wants to heal their tears without having to do it surgically. There are some patients that do need surgical intervention for their tear, depending on their situation and depending on the condition of their tear. But this is something that is, as Dr. Rogers said, individualized and personalized depending to the patient's need. Um, uh, so one question that we have been asked is, are these therapies safe? And how safe are these therapies for not just for rotator cuff tendon, but for the spine and the joint and other conditions?
Yeah, so that's actually the first question every patient should ask when you're talking about a new therapy. Is this safe? You know, every drug on the market has been vetted by the FDA for safety and efficacy. And we shouldn't just naturally assume that because these are your own cells, your own blood, your own bone marrow, or your own fat, that they are safe. But I'm happy to say that bar none, this is probably the safest medical treatment in orthopedics today. Safer than steroids, safer than taking aspirin or ibuprofen or Aleve. There are thousands upon thousands upon thousands of patients that are studied under clinical research protocols. Some of them followed for as long as 12 years to see if they're growing tumors or to see if they're having any kind of complication related to the injection of cells. And I can say, other than the soreness that you have from, you know, the injection for a couple of days, there really are no adverse events. There certainly are no serious, what we call a serious adverse event, right? So a cancer or a heart attack or a stroke or something like that. Nothing like that reported at all in the medical literature. And personally, knock on wood, you know, having injected these things into thousands of people over the past decade or more, no complications in my patients as well.
Yeah, it's been 30 minutes. Our time is up, Dr. Rogers. Thank you for everyone who has joined us. Our next Ask the Docs series is on February 3, I believe. Yes, every first Wednesday of the month from 12:30 to 1 o'clock, we answer all your questions regarding any orthopedic condition or regenerative treatments like PRP and cell-based therapies. So if you want to learn more about rotator cuff tendinopathy and tear, we are doing a webinar next week. And we talked more about the nitty-gritty aspects of tendon injuries and what a rotator cuff tendinopathy is, and more detailed information on platelet-rich plasma and cell-based therapies. So feel free to go to our website to join us and register for the webinar. That will be next week on Wednesday.
We also have a YouTube channel, which has about 20 videos on there. And you just go into YouTube and search the name of our practice, San Diego Orthobiologics. And you'll see those videos, some past lectures that Dr. Ambach and I have given, some at some medical conferences as well. And our website, sdomg.com, of course, has a lot of great information. So, and we're happy to take your questions if you want to call us or email us as well.
Right. Thank you very much for joining us. Till the next time.
Thank you.
Bye.